Chapter 15 is on OCD and the related disorders of that. So first, OCD is characterized by being unreasonable thoughts and fears, which is the obsessions, that lead you to do repetitive behaviors, which is the compulsives. A person with OCD uses the obsessive and compulsives as a way to decrease their anxiety. So let's see, some common obsessive thoughts are those regarding contamination, religion, doubting, aggressive urges, and accidental harm to others. Some examples of obsessive thoughts would be fear that they'll get sick if they touch something, fear that if they don't pray every night for their children will die the next day, a man who has a thought that whenever he sees a blonde woman, he should kill her. So those are some examples of some obsessive thoughts. So some common compulsions, they are checking and counting rituals, washing and scrubbing, praying, touching and tapping, and rearranging items. And there's others as well. So some examples of this would be going in the same door that you came out of, turning off and on the light switch 20 times before you leave the room, and those type of things. So some examples when we put these two together would be a person whose obsession is with contamination. They will wash their hands every time they touch something. That could be one for someone. Let's see, a person whose obsession is that they will cause accidental harm to self or others. They may get up throughout the night to make sure the door is locked so no one can come in and hurt anyone, no one can break in and hurt anyone in their family. A person with the obsession of fear of doubt, they could return home or during the day, or they could just continually check to see if the stove is turned off, if the iron is unplugged, if the doors are locked, those type of things. So OCD, it is diagnosed once the thoughts and behaviors consume the person to the point where they interfere with personal, social, and or occupational functioning, and there is no medical diagnosis to explain the obsessions or the compulsives. With that being said, we all probably have a little bit of OCD tendencies, okay? But to be able to have a true OCD diagnosis, it has to interfere with your personal, social, or occupational functioning. A person with OCD, they know that these thoughts and behaviors are unreasonable, but they are not able to control them. The behaviors, the compulsions, they use that as a way to decrease their anxiety. So some related disorders. The first one is dermatillomania, and this is known as skin picking. This is a self-soothing behavior, which means that a person, that just means basically the picking itself is not necessarily causing a positive sensation, but just the action of it. They're finding comfort in or soothing themselves by the picking action. And this may lead to medical complications as well, because they may get lesions from the repeated skin picking. Nail biting would be the next one, and that is onychoplasia. This is also a self-soothing behavior, and it's most often seen in children, and it usually is decreased by the age of 18 years old. The antidepressants, SSRIs, have been proven effective in treating onychoplasia. Trichotillomania is known as hair pulling. This is another self-soothing behavior. The onset is most often seen in children and treated with behavior therapy. Kleptomania, this is known as compulsive stealing. This is a reward-seeking behavior. The other ones were self-soothing. This is now a reward-seeking behavior, which means that the reward is not the item that was stolen, but the thrill is stealing and not getting caught. And this is not the same as stealing items needed for survival. Kleptomania is often seen in females, and we often see patients with this condition within the legal system. Oniomania is known as compulsive buying. This is also reward-seeking behavior in which the pleasure is acquiring and purchasing new objects. Often the objects are used very little or not at all, and it is said to run in the family. Hoarding is having excessive possessions. It involves having acquired excessive animals or apparently useless things. They will live in cluttered spaces which are inhabitable, and it has significant distress and impairment on the patients. Hoarding can be seriously compromise the person's quality of life, health, safety, and can also become a public hazard. Body dysmorphic disorder. This is where a person has a preoccupation with the image or a slight defect in physical appearance. So basically here a patient is worrying about a defect that they see. It could be one that they just imagine, or it can be a little small one. And they're blaming all of life problems on this one little flaw. So what they do is they go and they have elective cosmetic surgery to fix that flaw, but are often dissatisfied and they'll find another flaw, and then the cycle just continues and they will have multiple cosmetic surgeries. Assessment. A person with OCD will seem tense and anxious, and when the obsessions are strong, they may have difficulties concentrating while their physical appearance seems normal. So they'll seem normal on the outside, but then they'll just be real anxious and tense on the inside. A person knows that these obsessions and compulsions are irrational, but they are not able to stop, and they often feel as if they're going to go crazy due to having performed these rituals. And also a person with OCD that often are not able to fulfill their roles that are required of them, especially as they get older. OCD affects a person's personal, social, and occupational life, and oftentimes can be managed as a child, but once as we age, we have more responsibilities put onto us, and as we get older and we have those more responsibilities, we often see that they are not able to cope with it as they did with the child, because the rituals are now interfering with their abilities to perform those roles and responsibilities that they have now. Outcomes. Patients may not be able to fully stop their OCD behavior. Most of them, they will not. However, have an attainable goal would be best for the patient. And these goals would be like to spend less time performing rituals, complete activities within a stated time frame, and that they are able to use behavior therapy techniques. So those are some outcomes that would work well for those with OCD. Some interventions: you want to promote your therapeutic communication and encourage the patient to discuss their obsessions, compulsions, or condition. OCD usually intensifies as the stress in a person's life increases. Therefore, whenever we are teaching a patient with OCD, when we're teaching them the relaxation behavioral techniques, we want to make sure that it's not at a time when they are at a high level of anxiety. We want to make sure that their anxiety level is low so they are able to learn. So remember back to last chapter when we talked about mild to moderate anxiety and that they're still able to learn better at the mild level than the moderate, but moderate still can learn. So you should never stop a ritual the patient is doing. By doing this, you will increase their anxiety. Instead, you're just going to want to set guidelines or goals. And remember that for goals, your patient has to agree to the goals. So just like in your nursing care plan that you've used and learned about, it's useless to have a goal that is something the patient does not desire, because the likelihood of you meeting that goal is very minimal. So you can tell the patient that they have 30 minutes to get ready for breakfast, and your goal would be to get ready in 15 minutes. So you can decrease that time until your goal is met at 15 minutes. Another intervention would be to have a schedule made for the day, and this will help the patient to stay on task. So let's say 8 o'clock is breakfast. At 8:20, they need to go put their clothes on. At 8:25, they need to be brushing their teeth. Treatment. OCD is treated as an outpatient and usually takes a person with OCD to have a sense of feeling just overwhelmed before they even seek treatment. But once they do seek treatment, the optimal treatment is a combination of therapy, such as your cognitive behavioral therapy, exposure therapy, and also your medications as well. So the first line medication are your SSRI, such as Zoloft. If that doesn't work, then they'll go to your second line of your SNRIs. Just remember, SNRIs work in the same way as SSRIs, but they just also add the reuptake of norepinephrine as well as serotonin. So if a person with OCD, neither one of those really work, they usually will then add in a very low dose of antipsychotic, and this has been kind of, they don't really know for sure. There's been different studies saying yes, it works. There's been studies that saying, just aggravates and intensifies their OCD. So it really just depends on the patient. But just know SSRIs and then SNRIs, and if those don't work, they may add in a antipsychotic.